By Colonel Alok Sati. He's a prominent cornea surgeon at my hospital only, and sir will be talking about correcting the refractive error from cornea to lens. Sir.
If we look into the good morning, everybody, the topic which I have been given by Colonel Pradeep is refractive procedures, cornea and lens. The key concepts in this topic is why do we need this? Because we have to have increase in functionality and the quality of life of the patients. For this, we have to choose the correct tool, and then we have to reassess our decision whether we should operate such patients or not, and then we have to demand a skill set for it, like which machine, which lens will work for it. That's important. So broadly, if you look at, there are three kinds of procedures. One is cornea based, one is lenticular based, and one is the combination of these two procedures. So cornea based procedures, if you look at, there has been a paradigm shift since 1980s. Initially it was PRK. I'm not going before that because I'm going to those procedures which we are still doing, then LASIK, and now SMILE and Contura. This is in the pipeline. So if you look into the PRK is normally done in patients in whom LASIK is contraindicated, and especially not contraindicated exactly, but to some extent, and we operate myopia to the extent of 3 to 4 diopter. And there is the Athens protocol for keratoconus. There also we perform PRK. And this is a short surgical video of the PRK. If you look at here, what we do
with PRK, your ophthalmologist removes a layer of cells called epithelium from the center of your cornea. These cells may be removed with an alcohol solution, a special type of brush, or with a specific surgical laser to remove a precise amount of corneal tissue. After reshaping the cornea, your ophthalmologist will place a bandage soft contact lens on the cornea.
If you look at what are the issues with the PRK, there are basically two issues with the PRK. One, the corneal haze, which persists for at least a month. It has been seen in some of the patients. And second, the epithelial healing. And these are the two limitations which provoked the innovators to look into another option, and that's what is the LASIK. This LASIK procedure, what we do is up to 10 diopter, though it's quite variable depending on the surgeon, depending on the corneal thickness. And we perform LASIK either by microkeratome or by femtosecond laser. And this is how the procedure is being performed. So after making a flap, now you see we are making a flap first, and then we are subjecting the cornea to the excimer laser. It is basically a sort of a keratomileusis what we are performing here. And this ablation is what creates, and then we again reposit the flap back. But the issue with this LASIK procedure is that the flap related complications can be performed in, there may be multiple occupational hazards, especially there are certain divers where it may not work, there are certain professions where it may not work. So the thought came, or thought provoked, that why not to have a flapless procedure, and that's what is known as SMILE. This is where we create an incision of small incision of about 3 mm, and we remove a lenticule through that 3 mm incision, and it gives high quality vision with less complication rate. And currently this is what is coming up in a big way, where it's similar to LASIK, but here a special topolizer is being used, and we mark 22,000 unique elevation points on the cornea. That's how it being modulated, and multiple aberrations which come up post-op, they are taken care of by these procedures. So if you look at our center, we have basically two procedures what we perform at our center. One is the SMILE and second is the ICL. And we do smile up to 10 diopter with astigmatism up to 5 diopter. And we have a very strict protocol at our center, like we take age more than 20 years, we perform cycloplegic refraction, we do the dry eye evaluation very properly, and then the corneal topography is very important because that's provide you the exact K reading whether a person is having, the ectatic disorder or not. If it is there, it's absolute contraindication, and then detailed fundus evaluation. And this is how the procedure is being performed. So this is how we perform SMILE procedure. We first create a plane at the lenticule level, that's a posterior level, and then this is the at the cap level, what we call it, then the side incision, and then we bring the patient's eye under a microscope, which is already there in the SMILE procedure, SMILE machine. Here the patient's cooperation is very important. And then this is the very small incision. We are first creating a plane anteriorly, then posteriorly. And after that, we remove the lenticule. This is how we have removed the lenticule. And this is a short procedure. Now, if you look at our experience, this is our experience from 2019. One side is showing the number of patients, and one is showing the number of patients attaining 6/9 to 6/6 vision. So if you look at, it's almost closer to the number of procedures that we have done. So this is the predictability of this procedure, which I want to highlight here. As far as complications are concerned, n number of complications have been enumerated in the literature, but to us, it is the suction loss, and that too in a few patients. We managed it considering the protocol of the machine. Sometimes we have gone against the protocol also, and that we are going to publish soon. Now, the other procedure that we do at our center is implantable Collamer lens, where we normally do it, though we can do it even in the patients who are indicated for the SMILE, but normally we resort it to those patients who are not fit for the SMILE. And we have a very strict preoperative protocol like the SMILE, and the procedure is this. It's not working again. So what is most important in ICL procedure is that it's a loading, which is very important, and once it is being loaded, it's relatively easier to perform. But the most important thing is that we should know that the patient is under topical. We cannot afford to have iatrogenic cataract formation, so we have to be very careful. This is 3.2 mm incision. It's easy to perform through 3.2, unlike 2.8. And then we have to instill the viscoelastic into it. This is what we are performing, the toric ICL basically, under Callisto microscope. And this lens delivery has to be very meticulous and very smooth. And if you see, there is a hole in the right side that shows that the position of this lens is correct. And after that, you have to tuck in all these 4 haptics, considering the toricity into account. (178° the axis where you have to place it, and finally we have placed everything, and this is how it comes out. So till date, at our center we have performed around 58 ICL procedures, and to our surprise, most of them have got 6/9 to 6/6 vision on day one. We have done even one hyperopic ICL. The difference between hyperopic and myopic is that the hyperopic ICL doesn't have hole at the center, so we have to do preoperative PI, or even intraoperative PI also works. In 2 of the patients, we have found steroid-induced IOP rise, and no regression has been seen till this date. As far as complications, I have already rattled out. Thank you.
Thank you so much, sir. And the best part was that all the videos that you showed were in real time, and one could easily understand that these procedures, though they seem and sound very simple, are not so easy to perform. Thank you so much, sir. Any queries from the audience?
Sir, I wanted to know what is the minimum refractive error that you can take away with smile? What is your experience?
Yeah, 0.75.
0.75. And in that patient,
0.75 spherical. We have to have.
And do you think the new machine will help in avoiding complications such as suction loss or?
Yeah, now, currently the machine which we have is the old model. Now the new model has come by Zeiss, that is 800.
Yeah.
So there the duration is just 8 seconds. So obviously, suction loss time will definitely happen. And now Silk has also come up by Alpha.
Yeah, J&J.
So do you have any experience with IPCL also, or you're doing only?
Yeah, IPCL I have done in AFMC, and what I have found, what difference I have found between IPCL and ICL is that ICL is a little thin, easy to manipulate inside the eye, and very easy delivery. Okay. And it's very, very pliable and very smooth, very shine, whatever you expect from a lens to have. Whereas IPCL is a little thick, so you always think it may hit the lens, normal lens. Okay. So that's, otherwise both work effective.
Thank you.
Thank you so much, sir. In the interest of time, I'll request our next speaker, Dr. Neha Mita. She is the director at Avantika Eye Care and Glaucoma Services Center. She is going to enrich us about arresting pediatric myopia and the ideal prescription methodology.
Good morning, everybody. So I'll be talking about the arresting pediatric myopia. Although this is a very extensive topic, I have tried to make it very, very concise. So let's begin with it. How big is the problem of myopia? So in 2000, we expected about 165 million people to be myopic in the world, whereas by 2050, this number is supposed to go up by 4,758 million myopes all around the globe. Now, what are the various proposed theories? The first one being the genetic inheritance, although various other genes are also, postulated to play a role. But parental inheritance is one of the most important things that we need to take care of when the patient is walking into our clinic. So if both parents have glasses, the chances of child getting myopia is about 3 times. Various socioeconomic factors like higher levels of education, private schools, urban living, constricted living spaces, girls, since they have a less tendency to go out and play. So in these cases, higher tendency of myopia is seen, increased near activity and lack of outdoor activity. So now, what are the possible interventions to arrest myopia? So one is the new myopia control glasses, contact lenses, lifestyle changes, and pharmacological. We'll just take up each one of these one by one. So before we get into the optical treatment, it is very important to understand what is hyperopic defocus, the term which is being very rampantly being talked about these days. So what happens is when you are correcting myopia with your normal glasses, do we have a pointer? Okay. Normal glasses, so in the center at the fovea, your image is exactly forming at the fovea. However, with the conventional glasses, in the periphery, the image is forming behind the retina, thus causing a hyperopic defocus. So what does that do? So when you use these special glasses, which are made of special lenslets, thank you. So when we're using these special glasses, so what happens is instead of conventional glasses where this image was in an uncorrected myopia, all this image is in the front of the fovea and these are outside. When you correct them with normal glasses, this still remains outside. Whereas when you correct this with these myopia control glasses, even the peripheral image is now being formed at the retina, thus decreasing the hyperopic defocus. Why this is important? This is because the stimulus for the axial length to increase, for the myopia to increase, is blur. So whenever our brain perceives that the image is forming behind the retina, there is a signal that goes down that the eyeball needs to grow. Eyeball needs to enlarge in size so that even this peripheral image falls on the retina. This blur is responsible for the axial elongation and your increase in myopia. So these glasses are typically meant to take care of that. These are currently being marketed by Essilor and Hoya. Hoya ones are now being available in India also very commonly. A pair of glasses costs you about 15,000 rupees. So in patients in whom you feel there is accommodative lag, progressive addition lenses, bifocal lenses have also been used, but not with that great success. Earlier there was a belief that we should be under-correcting myopia. However, this is being now challenged. Yes, overcorrection is not expected, but adequate correction of myopia is required for proper control. We should not be under-correcting myopia. And for these, as I just discussed, these special myopia control glasses are expensive, and cost and availability is a limiting factor in Indian scenario. Coming to contact lenses, again so in contact lenses, the olden one is the orthokeratology, in which with no lens, this is the myopic cornea. When you fit the lens at night, this is how it is looking, and after overnight adjustment, there is reshaping of the cornea that you can see. Then in the daytime, the patient takes off the contact lens but still maintains that shape and does not need to wear glasses during the daytime. So this is the concept of orthokeratology, and it is known that it is shown to decrease myopia progression by 45%. Then moving to the more advanced methods are multifocal contact lenses, and one such being commercially available is by Cooper Vision, that goes by the name of MeSight. And again, it is working on the same concept of correcting the hyperopic defocus. However, what are the limiting factors here? Hygiene issues. We need to teach the child very well. Availability in India is still a concern. People are getting it from outside who can afford it. Then moving on to the pharmacological treatment. So various drugs have been tried over time, but only low dose atropine has made its mark. So various studies have come throughout the years showing the benefits of atropine. So the first study that came, Atom 1, I'm just telling you in brief about the study. It said that 1% atropine is effective in controlling myopia. Then came Atom 2, there were side effects of 0.01 atropine, 1% atropine. So they thought of reducing the dose, and they compared some doses, and they found that 0.01% atropine was good for controlling myopia, but axial length elongation was still happening. So that was a concern. Then it was the LAMP 1 study, which showed that 0.05% atropine is best in controlling myopia also, and controlling your axial length elongation also. LAMP 2, that was the final phase of the study, also said that 0.05% atropine is the best strength by all means, and its effect is double as compared to 0.01% atropine, and it decreases myopia progression by 64.5%. So yes, the studies do say that 0.05% is the ideal concentration. However, it is still not commercially available, and we can start with 0.01%. So important here is that it's not uncommon for me to see that people are coming and with prescribed low dose atropine in any kind of refractive error. The concept has come that you give it in any kind of refractive error and it will help, but it is not the case. It is only useful in simple school myopia. You see a 4-year child with -11 diopter square, that is congenital myopia, your atropine is not working there, so do not give. Patients who are coming with -4 diopter cylinder at 5 years of age, there is no use of giving low dose atropine there. So the prescribing schedule is 1 drop once at night for 2 years for children less than 16 years of age. You have to, hammer it into the head of the parents that if you leave the drop in between, there will be a rebound and the myopia will increase even with further speed. I typically tell them to buy, a stock of at least 6 months. There should not be a gap. I tell them, if you can't do good to the child by putting drops, do not do bad to your child by missing the drops or discontinuing the therapy. So explaining about compliance is extremely important. Also, it is a very common mistake that you write atropine. They do not care to see that what strength they are buying. They see, oh, what madam had written was for 200 rupees, this guy is giving it to me for 30 rupees. So I typically explain them कि 30 रुपए वाला नहीं लेना है, 200 रुपए वाला लेना है. That is what is required. Okay, so not all myopes will respond to your low dose atropine. So what you have to do when you see your patient has already been using atropine for 1 year now, but still you see that the myopia is progressing. So first is to check compliance. Are they actually using it or not? What is the method of drop instillation? Second theory that has been proposed, that if you shift the child from HS dosing to once morning dosing, somehow the results improve, they respond better. Even if you feel you have shifted to morning dose and still there is not enough response, the child is still progressing, you have to shift the child to BD dosing from 0.01% once at night and once in morning. And if you still feel, or either instead of doing BD dosing, you can also increase the strength to 0.05%. People are using 0.1% also, and in fact 1% also, along with bifocal lenses. So it depends how fast your myopia is progressing, and you can adjust your dosage accordingly. Then coming to lifestyle changes. So you have the counseling time that you have to give. You have to decrease screen time to less than 30 minutes per day on phone. That's what I recommend. Switch to bigger screens from phone to iPads, and iPads to TV. Online classes, if they want to watch YouTube, please watch it on TV, not on mobile phone. Enroll in toy library, book library. We just tell the parents that do not give phone to them. But then what to do? You have to give the parents as well as doctors, you have to tell them what to do if you're not giving them phone. And then outdoor activity of approximately 14 hours per week has shown to significantly decrease myopia progression by 33%. And if not 14 hours, then at least 1 hour per day is highly recommended. Going to a sports complex, playing at night time is not helpful. That play has to be during the daytime. And I tell that even, going on the terrace is also a good enough. So just the take-home messages: choose your correct patient in terms of age, refractive error, progression, parental history. One or more methods of myopia control can be combined. You have to ensure and reinforce compliance. Affordability of these modalities has to be kept in mind. And outdoor play, do not underestimate its holistic benefits. Thank you.
Thank you, Dr. Neha. Thank you so much. In the interest of time, I'll request Dr. Talveer to take up the stage, and the questions can be addressed by Dr. Neha from the table itself. One question I wanted to ask you was that what will you recommend for somewhere a 6 or 7 year old child coming to you with that -2, -3 kind of myopia? What will be your first line of treatment?
Yeah. So the first thing is that when on my first visit, I would not prescribe atropine. I would we observe the child for 6 to 8 months. You see if the child is actually progressing. If you see even a 0.25 diopter progression, then I will start the child on 0.01% low dose atropine once at night. That will be my initial thing. If parents can afford, I will put the child on those glasses, special glasses.
With this, I welcome Professor Talveer Sidhu. She is at GMC Ludhiana, an ex-alumni of RPC. She is a prominent glaucoma specialist, and she'll be talking to us about the conundrum of glaucoma in myopia.
Good morning to everybody. So the conundrum of glaucoma in myopia is because this is not progressing. Please see. Yeah. So as we all know that nowadays the pandemic of myopia has already started. And in addition to that, myopia has been an established risk factor for glaucoma. And with the increasing age, as myopes are also increasing also aging, there is a six-fold higher risk of glaucoma in myopes. It has been shown in various studies that high myopia, it leads to early development of glaucoma, though there is not much evidence that it leads to early progression of glaucoma. So why does myopia lead to development of glaucoma? Is because of the mechanical effects on the lamina cribrosa. So there is stretching and thinning of the lamina cribrosa, as well as there are myopic deformations of the optic nerve head because of tilt and torsion, and because of the mechanical deformation of the optic nerve head, also the vascular supply of the optic nerve head gets disturbed, which can lead to mechanical pressure over the ganglion cell, the RGCs, which can lead to glaucoma formation early. So glaucoma in myopia is very difficult to diagnose clinically. Why? Because of the large peripapillary atrophy that can be present along with glaucoma in myopia. It is difficult to first ascertain what are the boundaries of the optic nerve head. So here we can see that there are thin black arrows forming the boundary of the optic nerve head, and this figure A actually shows a glaucomatous optic nerve head, where we can see that there is a bending of vessels right at the edge of the optic nerve. But similarly, in the lower picture, there is a large peripapillary atrophy and optic nerve is lost somewhere within. So the black arrows are actually marking the optic nerve head margins, and because of the stretching of the optic nerve head, it is difficult to ascertain where is the cup and where is the neuroretinal rim. And we can see that the vessels are bending right about here at the thick arrows. So that is how we can ascertain sometimes that what is the cup margin. Also in these discs, sometimes the circle of Zinn-Haller actually comes outside of the optic nerve margins, which can lead to a compromised blood supply, and there is a large gamma zone of peripapillary atrophy. Fallacies, when we talk about the clinical diagnosis, if we are not able to diagnose, we rely on the visual fields, and if not visual fields, we rely on our OCT. And we all know that most of the glaucomas in India and in our country, they have lower IOPs than 20 millimeter of mercury, because usually the higher IOPs will be shown in DVTs when you're doing it early mornings, and patients to us are mostly presenting in the afternoons or evenings when the IOP has actually come down. So while we are testing visual fields in in myopia, we see that there are 10 to 17% of high myopia without pathological changes of glaucoma. They have visual field defects, and what contributes to those visual field defects is first of all lens rim artifacts. So in any person who has a more than 4 diopter myopia, it is important to use contact lenses while doing the visual fields. All right, and after that, it has also been shown that the myopia itself, when there is an increase in myopia by 1 diopter, the mean deviation can actually decrease by 0.2 decibels in these eyes. So that also should be taken into effect. Along with that, if there are optic nerve heads which are tilted, they can have congenital defects in the visual field and RNFL, which can be present along with the tilt of the optic nerve head. Those also have to be kept in mind. If there is no family history of glaucoma and other risk factors of glaucoma are not there, so that the visual field defects, such visual field defects should be monitored for progression. Another important thing that happens in very high myopia is the papillomacular bundle defects that can be present in myopes in early glaucoma. So these should be ruled out with the help of a 10-2. It can be missed on a 24-2 because there is a 6-degree difference between each point on the visual fields that we do. Now coming to OCT. So once if our visual fields and optic nerves are looking like not very non-decisive about having glaucoma or just high myopic findings, then we tend to rely on the OCT in myopia. But OCT itself also has some fallacies. Don't worry, I'll come to a part where I'll provide some solution to all these problems. So when we do OCT nowadays, the neuroretinal rim width is actually taken into consideration most of the time, and the neuroretinal rim is actually taken from the Brooks membrane opening to the rim. So here we can see this is the Brooks membrane opening, but the rim on the optic disc margin is actually here. So because of the peripapillary and the gamma atrophy, not just beta atrophy is present, gamma atrophy is where actually your Brooks membrane is pulled away from the optic disc margin. So here you can see that the Brooks membrane opening has actually shifted away. So this was a child who was followed up for 6 years, and it showed that actually the Brooks membrane opening has shifted away from the optic disc margin, which will not give you very good neuroretinal rim findings. So this is another thing that we have to take into consideration. Segmentation defects can also happen on OCT. So here we can see this is a girl who came to me, was diagnosed with glaucoma. She had a very large optic nerve head, -16 myopia, and once we did a retinal nerve fiber layer thickness map, we saw that the circle that is actually 3.54 millimeter in diameter, it was passing through the peripapillary atrophy area, which was showing a falsely low RNFL. So that this is what can happen in highly myopic eyes, that the peripapillary retinal nerve fiber layer we cannot calculate because there is definitely it passes through the peripapillary atrophy areas. So later on, what most of the doctors have done is they are looking at the deviation maps which can be seen in glaucoma. But there is some fallacy about the deviation maps in glaucoma, in myopes also. There is always a temporalization or temporal shifting of the retinal nerve fiber layer that happens in high myopes. So in a normal person, as you can see here, that the retinal nerve fiber layer is actually going along very well with the arcade, but here also you can see that the arcade itself has shifted temporally, and this is the result of this. So what happens is, we can see here that there is a temporal shift in the retinal thickness map that is happening, which is giving us a falsely low RNFL in the infratemporal quadrant in both the areas, which is giving us the inferior neuroretinal rim or the inferior RNFL as a thin RNFL compared from the normative database, which includes non-glaucomatous eyes. So what happens here is there is a very high temporal neuroretinal rim and a low inferior rim. So it is important that once you are diagnosing a glaucoma person with myopia or doing OCT, you should look exactly at these maps, that if there is temporalization of the retinal nerve fiber layer, do not think that otherwise the retinal nerve fiber layer has been thinned. So nowadays what is happening is, we are all looking at NFAS images. So here also we can see this is actually the NFAS image, and it is giving us some thickness of the retina. We know that the retinal nerve fiber layer, although shifted temporally, here also although it has shifted temporally, but we can see a very good thickness map on the NFAS image. Similarly, if you look at this eye, here you can see a wedge-shaped RNFL defect, which is actually corroborating with the visual field defect, although some peripapillary atrophy is present. So NFAS imaging has been shown to give a very good picture. Also, people have combined the wide field OCT angiography along with the retinal thickness maps. So here you can see that there is a RNFL defect which is actually the optic disc ahead, and you can see there is retinal thinning which is corroborating with the visual field defect. So this is important to note that you can use various imaging modalities on the OCT. It is important to note that the ganglion cell thickness actually has a very good sensitivity and specificity for picking up glaucoma in high myopia. What happens in, can I please take just 2 minutes because I'm going to finish this?
Yeah, carry on.
So in ganglion cell layer thickness, you will see that the ganglion cell thickness is actually thickest along the superior inferior part of the macula. Here what happens is, if you actually look at the ganglion cell thickness in glaucoma, you will be able to see that it corroborates with the horizontal thinning of the retinal nerve fiber layer. Here you can see a wedge defect which is actually going up to the horizontal raphe on the temporal side of the macula, which is giving rise to this visual field defect. Similarly, in myopia also the same thing can be done. It is called a GCIPL hemifield test. So this is a very significant thing that can be seen in the eyes. It is important that you do a intra-eye comparison. Intra-eye comparison means that you compare the superior GC the ganglion cell layer with the inferior hemifield ganglion cell layer. The accuracy is actually very high, 92% and 95% specificity. So another thing is glaucoma loss volume, which is the ganglion cell loss volume, which can also be seen in myopia. So the conclusion is, a solution to this problem is that when you look at a person who has come for glaucoma, also has high myopia, please look at everything. If there is a high IOP or there is a normal IOP with low corneal hysteresis, if there is neuroretinal rim thinning, even if this is not diagnosed, there is a visual field defect and there is a GCC hemifield test also is defective, then you can definitely term a myope with a glaucoma and you can treat. So this is the conclusion. Thank you so much. Another important thing is, don't ever think that you do not need to do gonioscopy in a myopia person. They might have angle closure. Always do gonioscopy in every person you suspect of glaucoma. Thank you.
Thank you, Dr. Talvi. In the sake of time, I request Dr. Ruchir Tiwari to please take the stage. Any questions to Dr. Talvi may be directed to the table, please. Dr. Ruchir is the director and owner of Tiwari Eye Center at Noida. He is a prominent retina surgeon with a special interest in pediatric RD and ROP cases.
Good morning, everyone, and thank you for being here. We were hoping to have a few listeners for our IC, and I think all of us are really happy to have you here. So I think my talk is going to be the saddest talk of the IC, but I'll still try to make it interesting. So when we talk about the myopic fundus, high myopia has characteristically been defined as a refractive error of 6 diopter or more with an axial length of 26.5 millimeter or more. However, these eyes do not show the characteristic pathological myopia changes. So the classic lesion of a pathological myopia is a posterior staphyloma. Unfortunately, till a very long time, till recently, we did not have a definition of a posterior staphyloma. So this was solved by Spade when in 2013 he defined a posterior staphyloma as an outpouching of the wall of the eye with a radius of curvature that is smaller than the radius of curvature of the eyeball. So now we had a definition of posterior staphyloma. With the advent of better imaging technologies such as Websource OCT and spectral domain OCT, now we have a better understanding of the myopic fundus, and a new term of myopic maculopathy has been introduced. So no discussion of myopia can start without Curtin staphyloma. Curtin was the first one who gave us a definition and a characterization of the different types of staphyloma. There are 10 types of staphyloma defined by Curtin. 5 are primary and 5 are compound. So compound are a combination of the different types of primary staphyloma. But then again, this is a fundoscopic finding. This is a clinical examination based finding. It does not take into account the layer wise changes that are happening in myopia. This was added upon by Ono Matsui, who did an MRI-based 3D reconstruction of the eyeball to describe the different types of Curtin staphyloma, and this led to a renaming of most of the Curtin type staphyloma into wide macular, narrow macular, peripapillary, nasal and inferior, and the other types, simply because the number of patients you see with these type of staphyloma vary according to the type of staphyloma that is there. So what is myopic maculopathy? Again, myopic maculopathy is a recent terminology. It is based on the concept that the retinal changes in myopia that happen because of the atrophy of the choroid. So basically, it's the choroid that is changing, which leads to all the visual changes in myopia. So international classification of and grading of myopic maculopathy starts from no macular lesions to a tessellated fundus, diffuse choroidal atrophy, a patchy choroidal atrophy, and a macular atrophy. Also, along with this, specific lesions such as lacquer cracks, myopic neovascularization, and fuchs spots have been added into this classification. So again, if we look into the progression of myopia, we see it changing from a tessellated fundus to a stage of macular atrophy in different patients. This is a representative image which shows all the described changes. Figure A is a tessellated fundus, figure B shows a peripapillary atrophy, C is showing lacquer cracks, followed by patchy atrophy, myopic neovascularization related atrophy to patchy related diffuse atrophy. Again, newer terminologies have been introduced. Myopic traction maculopathy and dome-shaped macula. These are simply OCT-based findings, which we now come to know, which we now got to know about. So, myopic traction maculopathy is a type of macular schisis that develops at the posterior pole as a result of the axial elongation as well as the tangential forces of the ILM. And dome-shaped macula is a sort of inverse staphyloma, wherein there is an inward bulging of the sclera, leading to a thickening at the posterior pole. So what is myopic traction maculopathy? As described earlier, it is a macular schisis. So classically, it has been described on the location of the schisis, whether it is extrafoveal, foveal, whether the entire macula is involved or just a portion of the macula is involved. Recent publications also suggest towards the incorporation of the tangential traction component, and this publication by Parolini et al. Describes in a very beautiful way the evolution of macular schisis from a simple schisis to a macular hole as well as to retinal detachment. Dome-shaped macula is an interesting concept. This is I first learned about it in 2011 or 12 by seeing one of my patients. We actually published this case. This patient was being treated as a case of CSR at another place, and we realized that this was something else. And on reading the literature, I realized that the patient was actually a case of dome-shaped macula with neurosensory detachment. Now, this fluid does not respond to anything. You do PDT, you do laser, you give injections, nothing works, and it goes away with time. So I'll come to a few case-based discussions after this. So the first patient is a 16-year-old boy, came to me with a sudden blurring of vision in his right eye. He has history of high-powered glasses in right eye compared to the left eye. BCVA was 660 in the right eye and 69 in the left eye. When I look at the fundus, two or three things are very much apparent. Right eye has a very much higher myopia grade compared to the left eye. The disc is large in size. There is larger area of peripapillary atrophy compared to the left eye. And there is a small red dot. I'm not sure whether it's visible on the image, but there's a small red dot at the fovea. On doing an OCT, I find this to be a hyperreflective mass. So this is a case of, and to confirm the diagnosis, I do an angiography which does not show any leakage at any point in time. So this is a case of a macular hemorrhage due to a lacquer crack, and the treatment is only observation. Nothing is required in this particular case. No displacement with gas, no anti-VEGF injections are going to help this child. And when this patient came back six months later, the bleed had resolved and the vision had improved to 6/12. The second patient is a 65-year-old male. So look at the contrast in the age of the patients. This is a 65-year-old male complaining of sudden onset of blurring and irregular vision in his right eye. Left eye has already been lost to macular atrophy. BCVA is 660. 6 months back, previously recorded BCVA was 6/24. When I look at the OCT, this looks like an inactive sort of a membrane complex at the fovea. However, when looked closely, there are two separate components to it. One is the lower part, which is a well-defined membrane complex, and then there is a mildly hyper-reflective area. That is actually SHREM, which signifies disease activity. And if we also look at the above area, there is a small intraretinal fluid component. So this patient has an active myopic MNV, which requires anti-VEGF treatment. This patient received one anti-VEGF injection, and this is post-op after 1 year. Now, if you compare it with the previous image, that SHREM component, the hyperreflective material component, has gone away. The membrane complex is still there, better localized as compared to before, and there is no intraretinal fluid. BCVA was maintained at 6/24. So what is myopic MNV? Again, it is a type of choroidal neovascular membrane that is seen in degenerative myopia. Now, how is it different from other type of MNVs? You do require to do an angiography in most of the cases, because this being a very inactive form of CNV may not require treatment in most cases. If there is activity described both on OCT and angiography, the first line is anti-VEGF, and unlike other type of CNVs, this does not require a loading dose. You need to give one injection and then observe the patient monthly. If any activity is noted, then again only further injections are advised. The third patient is a 32-year-old male, bilateral high myopia with cataract surgery done 3 months back. So prophylactic laser, barrage laser was done in both eyes. Patient had lots of lattices, peripheral degeneration. Right eye did develop a retinal detachment with vitreous hemorrhage after the cataract surgery, which was operated. Now, this patient came to me with a sudden onset of floaters in his left eye. This is the fundus image. This looks more or less okay. But this area shows me a vitreous membrane. So this patient has developed an acute PVD related floaters. So even in patients where laser has been done, there is no guarantee that no new lesion will form. And to my surprise, when looked closely in the superiotemporal region, just anterior to the equator, there were 3 large horseshoe tears which were posterior to the laser barrage that I had already done. So this patient underwent barrage laser again, and he was doing all right. The next patient is a 60-year-old female with a gradual blurring of vision in her left eye over the last 2 years. She's been pseudophakic for the past 10 years. BCVA was 6/60. The OCT revealed this picture. Now, this is a classic case of a myopic traction maculopathy, where you see that there is an outer retinal schisis along with an inner retinal schisis, as well as this patient is very likely to go into a macular hole formation along with a posterior pole retinal detachment, characteristic of a pathological myopia. So this patient was diagnosed as MTM. She was advised pars plana vitrectomy along with ILM peeling and gas. 6 months later, her BCVA improved to 6/24, and this is the OCT picture from that time. Then again, not all patients come to you like this. This is a 62-year-old patient, blurring of vision in her right eye for a year. She has history of anti-VEGF and gas injection 1 year back. BCVA was finger counting close to face when the patient came to me. I realized that the patient has a macular hole retinal detachment and a central atrophy. So this is the OCT picture, very difficult to capture in a patient who does not have central vision. As you can see, there is a detached retina along with a large macular hole. Again, this patient was advised pars plana vitrectomy along with ILM flaps and C3F8 gas. This is the fundus picture in the post-op time, and as you can see, the retina is well attached, there is no macular hole, and there is a large CNV that is seen, which signifies the previous anti-VEGF treatment that the patient received earlier. Not all patients come to you with this, and these are certain other complications of myopia with a giant retinal tear and a retinal detachment, and Colonel Pradeep, I think, will take up on that. Thank you so much.
Thank you so much, Dr. Ruchir. That was not a sad talk at all. It was very interesting indeed. Now we can take the questions on the table. Now I'd like to invite the very dynamic Professor Dr. Pradeep Kumar. He is Professor of Ophthalmology and Vitreoretinal Surgeon at Army Hospital R&R, New Delhi.
So, very good morning to everyone. Thank you so much for attending our IC. And I'd like to pick up from where Dr. Ruchir had left the retina discussion. So when we talk about the patients with globe, the myopes, there are 3 subsets that we are looking at. First are the adolescents. They have typical kind of RDs, but the issues are mostly with the pediatric hyperinflammatory response after you treat them. Then there are adults who have more peripheral breaks than usual, and these breaks have to be anticipated and dealt intra and post-operatively. And then there are aged patients where you have more myopic traction maculopathy and macular hole associated RDs. So this is our intended audience. Let me come to the young patients. These patients, generally we try to treat with buckling surgeries. Buckling in myopes are quite comfortable surgeries. Why? Because the indentation is easier, and since the aura is slightly posterior, it provides an easy view. So this is one typical case I wanted to show. You can see the marks which have been placed are at 20 millimeter, and the posterior suture has to be applied at 21 millimeter to allow sufficient indentation and support of the aura in this particular case. Now, a good idea is to drain these cases and do cryo on table, but in certain situations, when you have a large RD, you may encounter a situation of hypotony on table. In these situations, it's a good idea to inject saline into the vitreous, wait for some time, and do laser in the post-op setting. How it helps is that it reduces the amount of laser that you are doing and reduces the inflammatory response. This is another case which I wanted to show, where there was a choroidal detachment due to the hypotony induced by the RD, and the break had to be lasered at multiple levels. The MIVS surgery may not be easy in young myopes because of thin sclera, and a suture should be placed wherever required. The creation of ports, once they are done posteriorly beyond 5 to 6 mm after illumination of the globe, are generally difficult to suture. And The vitreous in pediatric age group is a formed vitreous. So when you are dealing with formed vitreous, as you can see in my first video, you have to be very careful with the PVD extension, and you can see the PVD is being gradually moved towards the anterior surface. We can't be as rough as in a routine patient. But when you do not follow this particular care and you try to peel the PVD forcefully, these kind of hemorrhages and breaks, as you can see up here. So shaving of the ora is generally not difficult once you have put a indenting element. So it is a good idea to place a 240 band buckle and then do your shaving of the ora to save the lens. The stability of lens itself may come into question during surgery, so one should be mentally prepared to place a 3-piece IOL or a iris clip IOL. Another issue in these cases is in old VRs, how to titrate the retinectomy. So the retinectomy under our experience should be titrated under air with a cautery. It helps in reducing the amount of retina loss to the surgery. The corneal incisions can sometimes give away. This is, my apologies. Yeah. There is the post-PK PFCL assisted RD. So in these cases, once you have placed a cannula at the corneal junction, it is very difficult that it will not require a suture. So a suture should be placed in such cases. And in this case, as one can see that we had this retinal detachment, and even through the post PKI where on the anterior segment view you felt that the image is not going to be good, generally the surgeries are comfortable, especially somehow in myopes. Coming to the adult age, the retinal reattachment has to be carefully titrated with the refractive requirement of the patient. So a careful IL power calculation is required, because most of the times we are going to perform a combined surgery in these cases. So once you have placed the IOL, you should be clear that what is the IL power that you are going to use. This should be arrived at by comparison with the other eye and the difference in the prescription between the two eyes. So this point is extremely important. You should always calculate the IL power based on the difference of spectacle prescription between the two eyes. This is a standard surgery I am showing with the intent of showing you this posterior pole image. One can see that this RP is not a healthy RP you see in a young adult. This was a 32-year-old male, and here you can see that the posterior pole is not very healthy. It's a thinned out choroid, and therefore during the surgery the laser became a issue, because once we are applying the laser, the spots were not coming. As you can see, it is quite, I am going on continuous mode, and in spite of that, just faint gray burns are seen. So the laser energy has to be carefully titrated. And as I had told earlier, these cases leak and a suture should be placed wherever required. The development of peripheral retinal degeneration is quite advanced by the time a high myope reaches 4th decade, and contralateral eye should also be addressed in these cases. And again, I am mentioning this was a small tear. Whenever you are pulling on the vitreous, this is where most of the young surgeons go wrong. You end up enlarging the break, and where a simple small laser could have helped, this kind of large laser extending till the periphery has to be resorted to. Intraoperative occurrence of multiple flap tears can also create a situation of GRT, which may require PFCL addition to control the GRT. And the myopic traction maculopathy, which is usually associated with these cases, can sometimes present with macular hole associated RD. So in this case, one can see that we peeled the ILM under air. This is the second case. Again, the ILM are so thin, they have to be repeatedly stained. It is not a easy go through like a standard macular hole. The issue is that the ILM cannot be seen. So ILM has to be repeatedly stained, placed over the hole, ensuring that the ILM flaps are able to seal this myopic hole. And most of the times when we go towards the periphery, we realize that there are no other causative breaks. So these are cases of myopic hole retinal detachments. And in most of these cases, once you're not able to find the primary culprit break, you may have to use dyes and even subretinal dye injection to allow identification of the break. This is again, I am showing another similar case where we had to place a ILM flap on the hole. In recurrent cases, when you are not able to identify the breaks, sometimes you have to carefully go toward the periphery, trying to dissect the membranes and keep indenting to realize that if a hole is present. This is another case where we have shown this was a re-surgery case. We did not even have an ILM at the macula. We peeled off the ILM, as you could see, from the hemorrhage area outside the macula and placed the free ILM flap under PFCL cover. In the older age group, the staphylomas are associated with MTM, and I was hoping Dr. Richard to cover the MTM surgery. Sorry, I have not bought a video for that. And the chorioretinal atrophy is usually associated with the difficult laser. And a major issue with the prognosis in these cases is that even though you may achieve retinal reattachment, the vision may not improve because of the underlying macular scarring. So these patients have to be carefully counseled pre-operatively that in spite of best possible retinal surgery, you might not get back your vision. Otherwise, the steps remain the same except the issue of MTM, which has to be dealt with. And these are the general post-operative images of these patients where you see extensive areas of chorioretinal atrophy at the end of the surgery, which is also marred with the progression of myopia. In the recurrent RDs, once they occur in the pediatric age group, they usually have poorer prognosis. So by the time a patient comes to you with second or third RD in pediatric age group, the prognosis is usually guarded and the surgery may even be deferred. And the subretinal dye injection technique is extremely useful in identifying the PVR breaks. For the sake of time, I can see the next session speakers here. I'll stop my talk here. Thank you so much for a patient listening. Thank you. I think we ended on time, so we can invite a couple of questions if there are. In that case, I'll thank my co-speakers and a big thanks to the audience for being here. I'll request everyone to come forward for a photograph.